Welcome to diseases. We're going to talk a little bit about the obstructive diseases. Remember, they go by the acronym CFC, BABE. We're also going to talk about some of the restrictive diseases and other things that can happen in your lungs. What we're going to start off with is basically the obstructive chronic bronchitis and or emphysema. When we combine these, we call this chronic obstructive pulmonary disease. And we're going to see that that's one of the things that is a major killer of a lot of folks. The American Thoracic Society has guidelines for the management of these two diseases plus the combined disease, which is COPD. Also, the Global Initiative for Chronic Obstructive Lung Disease, the current one is 2019, has come out and given us guidelines. Based on the guidelines of GOLD, this is how we're managing our patients who have COPD in order to give them a better quality of life, sometimes prolong their lives in some cases, and then take better care of them. Now, one of the things that you may want to think about is disease management. I'm going to talk a little bit more about that. I'm going to give you a couple articles on it. But it's really important that we work with our patients and give them some options. And you can become a disease manager. You can become a case manager. At one time, most of the case managers were nurses, but we're now getting some RTs doing that also. And so it's important for us to understand what it is and what we need to do to make sure that we're successful at it. So this is development of COPD. You can see there's a lot of different things that cause it. One of the problems that we're seeing in the third world or the developing countries is a lot of pollution. They do have some cigarette smoking. However, their pollution, outside pollution especially, is much worse. And as a result of that, we're seeing more COPD developing in these countries. This is part of the gold standard, and talks about how do we know that this is what you have. And there's various classes of it. You can see a little bit off to the side, the gold 1. They're telling us an FEV1 greater than or equal to 80%. And then gold 2 goes down from that to hit gold 4, which is the FEV1 less than 30%. So basically, if you're going to define this, the definition of this one is it's preventable and a treatable disease that unfortunately, even with medication, cannot have complete airflow reversibility happen. And so these patients will always have some airflow limitations. Other things that we see with this are comorbidities, and people talk about that. How bad are the comorbidities with these patients? If you think about COVID-19, we talk about the loss of a lot of the elderly patients, and they talk about the comorbidities. If you have heart problems, if you have diabetes, if you have kidney issues, things like that, that makes you more vulnerable to death. One of the articles I read this afternoon basically talked about the fact that if you have COVID-19 and you suffered in heart hospital cardiac arrest, the mortality rate in that is 100%. So you can see that comorbidities play a major role in the outcome of our patients. One of the things that's not stressed as much and really needs to be is that patients who have COPD suffer a lot of pain. They have a lot of chronic pain. And a lot of this is due to hyperinflation, dyspnea, depression, and then the reduced physical activity. When you get into third semester, we're going to talk about pulmonary rehab, and we're going to look at how do we do pulmonary rehab for these patients to make sure that we're doing and getting the best results for them. And like I said, it's something that's overlooked that we really need to pay a lot more attention to. So chronic bronchitis, the classic sign of chronic bronchitis is a chronic productive cough for 3 months in each of 2 consecutive years. And basically, one of the things that sends patients to their hospitals, to their doctors, more often than anything else, are cough, and especially cough with secretions or sputum production. And what the physician will do is they can run exams, they can do tests, they can do all this other stuff. If there's nothing else that's causing this, then we're going to rule in chronic bronchitis. Okay, and you can see with the American Thoracic Society, their definition is based on this productive cough. Emphysema, though, in another case, has to do with the airways, the bronchioles. And you can see there's a lot of destruction of the bronchioles, and there's not fibrosis with it. When we start to talk about some of the restrictive diseases, we're going to talk about fibrosis. And fibrosis, unfortunately, my definition of fibrosis is it's like taking concrete and pouring it into your lungs. You're not going to get rid of it. There's no way that we've gotten to the point where we can get rid of it. Fortunately for folks who have emphysema, they don't have fibrosis, but they still have this destruction. And one of the things we see with this destruction is the loss of the acuna, or the wall separating the alveoli. And when you end up with this big surface area, but a decreased area for gas exchange, and that's a major issue that we have. So patients with COPD basically have chronic bronchitis and emphysema. And the question is, well, which caused what? What came first, the chicken or the egg? In this case, what came first, the chronic bronchitis or the emphysema? It really doesn't matter. We can't tell you which one was there first, and we also can't really tell you, which one is causing most of the problems with this patient at this particular point. So some of the other things we see, as you can see, is that there's a lot of changes or airway remodeling happening with these two diseases. There's inflammation, thickening of the wall, the peripheral airway. There's an increase in the number of the submucosal glands. There's an increase in the number of the goblet cells, a decrease in the cilia, and as a result of that, what we're seeing is more mucus production, and it accumulates because we don't have the cilia to move it upward. If you remember in your pulmonary anatomy and physiology that we move about 100 ml of mucus every day, it just comes up, goes down our esophagus into our stomach, and then we never really know that it existed. So at this particular point, they're not moving this, and as a result of that, it starts to build up. There's also a lot of bronchospasm that's going on here on some folks, and part of that is because of the mucosal edema, the congestion, and everything else that goes on at this particular point. Okay. And air trapping and hyperinflation, we see this sometimes in the late stages. This is one of the classic signs of having an obstructive disease. So things with emphysema, there is permanent enlargement, destruction of the air spaces distal to the terminal bronchioles. There we lose the alveolar capillary membrane, and then we also lose the acuna, as we said, and we get this perfect surface area, but a very small surface area for gas exchange. What happens too then is that if patients are trying to breathe out, if they breathe too quickly, what's going to happen is the airways collapse on themselves. When they collapse on themselves, then we get all this air trapping and hyperinflation at that particular point. So there's also a lot of problem with the pulmonary capillaries. We have some of them will actually go shunt on us, and we're not going to get any gas exchange in those areas either. So we run into problems. Now, not to make you depressed or anything, unfortunately, as we age, we pick up some emphysema type changes in our lungs. This has to do with our lungs becoming more saggy-baggy as we age. And so, unfortunately, we're not going to have the type that you see with this type of emphysema. So there's the two major types, and your book does a really good job of that, explaining those. The panlobar is in your lower part of your lungs. The central senior is the proximal or central portion of the acunis. And that's your most common form of emphysema. And remember, cigarette smoking happens to be one of the major issues we have with patients who have emphysema. So it's estimated that somewhere between 10 and 15 million people in the United States either have chronic bronchitis, emphysema, or a combination of the two of them, which of course is your COPD. However, a lot of your folks believe that COPD is really underdiagnosed. This is almost the same thing we see with patients who have asthma. They'll tell you that some of those patients are underdiagnosed, and they'll also tell you that sometimes with people of age, the elderly, are overdiagnosed with asthma. And part of the reason people diagnose them is because they wheeze. What we need to remember is not that everything that wheezes is asthma. So we know that there's probably more than we'll ever know at this particular point. It is the third leading cause of death in the United States. It's fairly equal between males and females. It used to be more males, but now it's actually balanced itself out. The World Health Organization basically says that COPD will become the fifth most prevalent disease in the world and the third leading cause of worldwide mortality by 2030. So, like I said, you got to be careful of all the pollutants, and we're seeing a lot of pollutants coming from the developing countries. So the risk factors, and these are all based out of GOLD. As you can see, there's a genetic predisposition. That's your alpha-1 antitrypsin deficiency. Your age and gender, because we see COPD increases with age. When you're in the gestational period, low birth weight, respiratory infections as a child will also affect all of this, and then the exposure to all of the different things in the air, especially tobacco smoke. And remember, you don't have to be a smoker. You can get the second and third hand also. Social economic status is another one. Poverty has an inverse relationship with nutrition, crowding, indoor and outdoor pollution, infections, and things like that. We also see tuberculosis. Tuberculosis is something that has a tendency as we age to come back if you had it as a younger person. The problem is we thought one time we had eradicated it, but it's made its way back into the country and back into the world, if you want to think about it that way. And unfortunately, it's not the old TB. This is a new one that's almost drug resistant. And so this is something that we have to keep our eyes open to. So here are your key indicators. For those of you who may fall into any of these cases, please don't go see your doctor right away. But dyspnea, remember dyspnea is the patient telling you that they were short of breath. There's your cough, sputum production. What kind of history do you have? Where did you work? Where are you working at this point? Was there a family history? Did your family smoke? Were you raised in a log cabin and all you had was an old wood burning stove or something like that for heat and cooking? Your clinical indicators, any other risk factors, and then they're going to go ahead and do your PFT. Once we do the PFT, then we can go ahead and start to roll it in. So the three main tests we're going to do, the FEVC, the FEVC1, and the FEVC1 FEC ratio. And as you can see over here, that little graph, I'm sure Tree showed these to you when you were doing cardiopulmonary diagnostics, the different graphs that we see with patients who have normal lungs, restrictive lungs, and with obstructive disease. So one of the things is, how do we assess these patients? That's really important. And there's different things we need to look at. And so what is GOLD recommending at this point is that we take a look at the three different things here, the symptoms, the airflow, and the risk of exacerbation. And you do them all independently and then combine the results. You don't want to start saying, oh, okay, tell me this, well, you have it, you have it, you have it. It's much better to say, well, let's take a look at all of them, and then we're going to evaluate them, and based on the evaluation, then we can say, yes, in fact, you do have it. This is in your book. It's a really good picture, and it shows you all of the different assessments of airflow limitations. It tells you the different groups. What happens with this, it's almost like asthma now. We can either go up on your medications or we can come down on your medications. It's a matter of where are you at this particular point, what's going on with you, and how do we have to treat whatever happens to be going on with you. The BODE index is kind of interesting. This has been around for a while. This index isn't used to prescribe treatment. This index actually tells us a little bit about your mortality. It's really been evaluated and it's been compared to some of the pulmonary function tests and things along that line, and it's really a fairly accurate indicator, okay? So basically it looks at four things. It looks at your body mass index, your airflow obstruction, that's your FEV1. It looks to rate for dyspnea, how dyspneic do you get, and then exercise capacity. And then once you rate all of these, then there's a chart. And when you look at this chart says, another couple of years here, perhaps. Or hey, you seem to be doing pretty good, so make sure you take good care of yourself. X-rays are really good because as we do X-rays for our patients, we can take a look at them and see is the patient getting worse, unfortunately, at this particular point. Then you can do tomography of the chest. Serial PFTs will tell us too what's happening at this particular point. Remember, and I'm sure Therese told you this too, is if you go into the hospital and we want to do PFTs for you, our PFTs need to be done once you're out of the hospital and back to your baseline. Now, if you're never going to get back to that baseline you were at before you went into the hospital, then we have to establish a new baseline, and then we can go ahead and take it from there. So if you look at this, your book has got a really good overview of the manifestations that we see with COPD. As you can see, we have excessive bronchial secretions, bronchospasm, and then weakening of the distal airways and the alveoli. And then there's a number of slides. I'm not going to go through all of these. I'm just going to show you them. But this compares your vital signs and what is your patient with chronic bronchitis, CB, versus a patient who has emphysema. How are they similar? How are they not similar? Okay, but you can see both of these guys, when they're stable, could have normal vital signs until they get much worse, and then their vital signs will change a bit. When they have exacerbations, they become hypoxemic. Remember, the first clinical sign of hypoxemia is always tachycardia. Second one is tachypnea. And then you can just go through all of these. You can see the different things, what do patients look like. For patients who have emphysema, a lot of times what we're finding with those guys is they're very underweight. And part of that is because when they're trying to make, especially if they live alone, they're trying to make meals. They get too tired and they therefore don't want to eat and they won't eat. With COPD especially too, we see this because of their flattened diaphragms laying on the stomach. If they go out and have a really big dinner or something like that, it pushes up on the diaphragms and they can't breathe. So it takes quite a bit to try to keep these folks healthy because they aren't eating and they're not getting their vitamins and their minerals or things on that line. Hoover's sign is kind of an interesting one too. It's actually named after a physician whose name was Hoover, believe it or not. But basically, one of the things it talks about is that it's a result of the flattened diaphragms. When you take a breath in, instead of the chest wall going out over the lower portion of the lungs, it actually caves in, and it caves in because of that diaphragm. But it does tell you that the diaphragm is actually working, which is a good thing. The unfortunate thing is you have to look for this, otherwise you're not going to see it. And this is just an example of it. You can see here's the patient breathing. They're inhaling, and this is actually sunk in. And when they expire, it hasn't gone that much further at that particular point. And you can see other things with it, pursed lip breathing, A lot of the folks with emphysema learn how to do that themselves. We're actually going to teach ourselves how to do that. You can see with the chest assessment findings, because of all the air trapping and emphysema, decreased tactile fremitus, decreased chest expansion, because of that hyperinflation, it keeps the chest expanded. That's why they have barreled chests. They lose the 45-degree angle of the ribs and they become rounded, okay? And then the PMI, which doesn't refer to Pima Medical Institute, it's actually the point of maximal impulse, will often shift downward into the epigastric area. And so you're listening, and if you're listening over that area, you can hear the sound, the heart sounds at that particular point. And percussion note, definitely hyperresonant. You're going to hear diminished breath sounds, prolonged expiration, trying to get the air out. And like I said, if they exhale too rapidly, the airways will collapse at that particular point. And then diminished heart sound because you have all that air that's surrounding and in the chest. Here's some of the PFT results, some of your other ones that you see. Diffusion capacity, you can see it's decreased with emphysema. ABGs, what we're looking at. Severe ABGs, what happens with those if they're compensated. Tests that we see, hematocrit, hemoglobin, and basically with the electrolytes, one of the things that you see is you have an increase in your bicarb, because remember your bicarb is actually compensating for the increased or elevated CO2. As a result of that, your chloride has to go down. The body does not hang on to excess electrolytes. It has to get rid of them. Sputum, for the most part, emphysema is normal. However, with chronic bronchitis, because of all of that mucus that you're coughing up, there's been a lot of different things that we see at this particular point. And there again, chest radiograph, the bronchograms, we're going to see those with the chronic bronchitis. This is kind of a cool one. This was in your book, and you can see this is contrast. And they figure the contrast is there because of the swelling of the bronchioles. So how do we manage this? Go back to the gold. Like I said, people follow the gold standard, and that's going to help you with your patients. They've done a lot of research in that area. So they've updated, and they're getting much, much better every time they come out. So they're going to tell you how to manage your stable patients and then how to manage those that are having exacerbations. And part of this is disease management. Remember, I told you at the beginning, it's something that we want to get into. How do we keep these patients out of the hospital? How do we give them a better chance at life, make their life much better for them? Like I said, a lot of these guys are depressed, and they're depressed because they've lost a lot of parts of their lives, and they just don't know where to go or how to do anything at this particular point. And once you become depressed, then we see a lot of increased mortality with this too. And then there's ways of different things that we can look at to see where is this patient. And long-term oxygen has been known to increase your life because it actually does help you. You get over some of that hypoxemia. How do you qualify for it? Your PaO2 is less than 55 millimeters of mercury at this particular point. Which means it's moderate hypoxemia, oxygen saturation less than 88%, okay? And you can see that it's with or without hypercapnia confirmed over twice over a 3-week period, okay? Now, when we get into the oxygen part of therapeutics 1, we're going to talk about a Venturi mask. It's a high flow device. We can actually control the FiO2, the oxygen we're giving to you. Nasal cannulas are affected by your respiratory rate and different things along that line, and we're going to talk about those. So when we're dealing with these patients, we need to control their and give them a stable FiO2, it's much better to give them the Venturi device. Other things, pulmonary hypertension will get you oxygen. If you have CHF, it's another reason we'll sometimes give it to you. Polycythemia has its ups and downs. Polycythemia causes a lot of clumping and clotting with red blood cells. And as a result of that, one of the things that they will sometimes have their patients do is to go in and have some of the blood removed in the hopes of removing some of those red blood cells. So it's something that we need to understand. And they're going to reevaluate you, and if it's working, you can keep it. If you not, then they're going to take it away from you. But if it is, your hypoxemia has gotten better, your work of breathing has decreased, your myocardial work load has decreased, and you probably have a better outlook on life too. So this talks a little bit about what's an exacerbation. There's, different drugs you can use for it. One of the things we see with patients who have COPD, as they start to get closer towards that end stage, they have a tendency to pull away a little bit from their physicians and things that they know they need to be doing. When they start to feel bad, sometimes their physicians will tell them, call me, I'll go ahead and put an order in at the pharmacy for an antibiotic, especially if you're coughing up infected sputum. And, then let me know if you're getting worse, come and see me, or else let's go to the hospital. And they're like, okay. And they may go get the antibiotic, they may not. But sometimes we'll see these guys 4 to 6 weeks after this starts, and we see them because whoever has called 911 and told them to come get them and take these guys to the hospital. And then sometimes they end up having to be intubated. Sometimes they can end up on high flow nasal cannulas. Sometimes, especially if it's really, really bad and they're really close to the end stage, they may end up in hospice. So it's, one of these things that when we're working with these patients, we need to make sure that we take time and talk with them and, explain to them, these are some things you need to think about. So here's what they recommend for moderate exacerbations and then severe exacerbations. This is when you end up in the ER. This is where you're hospitalized or in ICU. And mostly these guys are in acute ventilatory failure at this point.